Well, thank you very much for having me today. Strange as the start has been to this, I'm Joseph Barney. I've actually worked with many of you guys that are therapists before in hairy situations and tragedy and good things too. And today they asked me to talk about airway management and COVID-19, which is kind of a focused area. And some of these slides will actually show you things that Dr. Overton has shown you already. I'm not an infectious disease specialist, but I've worked with him for many years and learned lots of things from him. So I'll just get started. And I also have to look back over my shoulder because of that. Suffice it to say, it's been a bad 2 years for everybody involved in being alive. In January 20th of 2020, the World Health Organization declares this global health emergency because of the emergence of SARS-CoV-2. And then March 11th, 2020, it declares it as an epidemic. And if you look at this website, which has actually been shown already by Dr. Overton earlier today, this is the Johns Hopkins kind of global COVID tracker that follows cases, deaths, mortality. And you can log on to it and then come back later the same day, like after eating breakfast, and it'll still be up and the numbers will be changed. And those are actual people who have died while you went to go get bacon and eggs or a bagel. So it's disheartening. And I think about it sometimes, you know, I'm in the hospital taking care of patients. Many of you take care of patients in the hospital or are about to be doing that after you finish training and become therapists, about how this makes people feel. I've felt many different ways about it. Some people would say they felt isolated. Some people would tell me that it is an incredible reflection of how fragile we are and how we're all, you know, one step away from not being alive. Afraid is one way that people would say they felt at many different points in this. And I think the thing that describes it the most for me is that it has made people feel, including myself, alone in a way that has never happened before. We sat in our houses, kind of locked up, which we needed to do, without being able to go see our families who live far away. Many patients sat in a hospital room, not being able to see their family, and died with a person like a respiratory therapist or a nurse in the room with them instead of their family who knew them really well. And for people who work in healthcare, it made us feel alone. I mean, you know, if you think about it, we wore layers of trash bags to be able to go into a room that we would normally have walked into and washed our hands and touched a patient with our hands. So I think that that really describes to me what this is like. And this is a cartoon sort of picture from a piece in the NPR called Undying Alone, and about this doctor who worked with patients with COVID to try and help them in their last moments of being alive. It's a really great read. It's probably a couple of pages if you have free time. But it was also this really overwhelming opportunity, this challenge for people to come together to fix this. And you know, what you just saw in the hour before that was how science and all the scientific community and people who, you know, work in virology came together to make vaccines to prevent this and treatments to treat it. But what really happens on the inside of the hospital are these people who came together to try and figure out how to mount some kind of response to take care of patients and to do the best they could in moments of fear. Many healthcare workers didn't know whether they were going to come home with COVID the day that they took care of patients. So where we're going to go for the next, not 50 minutes, because I'm trying to get my colleague up here earlier, it's just sort of a cursory background on the lung pathophysiology that happens with COVID, and clinical presentations of this, and some techniques for supporting patients, how we use high flow oxygen versus, ventilators, those kind of things. And we're certainly not going to talk about an extensive talk about ventilating strategies and things like that. And then just an approach to how patients are intubated and how this changed. One thing that COVID changed was the way that we are in a room with a patient, bar none, globally. And it also changed the way that we had to think about our own safety, taking care of people who are sick, which is also important. And then kind of summarize for you guys the need for streamlined kind of team approaches to take care of these patients. This is a little bit about the molecular mechanics of this killer. This is what COVID looks like. It's about 50 to 200 kilodaltons. It has these three main proteins, and this is spike protein, which is a glycoprotein that allows it to bind to the surface of cells. It binds to the surface of cells inside the lung. It binds to the surface of cells inside the kidney and multiple other places in the body once it's in a host, which is us or other animals. And it uses this spike protein to bind to ACE2, which is a receptor that is used in many biologic systems in the body, including regulation of blood pressure. ACE2 is kind of prevalent in lungs, which is one reason why COVID is very easily kind of taken up by the respiratory system and causes damage directly to pneumocytes or lungs, cells that line the lung. And it also is frequently found in blood vessels and kidneys as well as a couple of other places. And ACE2 is also upregulated in people who have high blood pressure. So it's kind of related to the fact that people who have some comorbidities like high blood pressure have higher morbidity with COVID because they have higher rates of this ACE2 receptor upregulated. In fact, people who take ACE inhibitors like lisinopril for blood pressure management sometimes have higher levels of this ACE2 receptor upregulated because of its response to being on this medicine, and those patients in certain cases seem to have really higher virility or worse cases with COVID. One of the people when COVID first came out that I worked with across the hall from me is a dear friend of mine and a lady who takes blood pressure medicine for this, and she was reading articles about it and terrified, and I wasn't really sure what the answer was because this was all new. We were all kind of figuring out new territory. And how it's spread among people is kind of important, and this sort of recapitulates some of the stuff that Dr. Overton showed you already, and that it's particularly spread by droplet, which are heavier and kind of fall down out of the atmosphere earlier, and then this would be more aerosolization, and then also by fomites, where these droplets land on surfaces and live for certain periods of time. Interestingly, you can see that this indirect fomite transmission, this is sort of a cartoon that shows you by color scheme how many times human beings touch their face and where they touch their face. So if you look at like blue, this area, your neck and ears, you have about 1 touch per hour there. Green, which is your nose, is about 3 times per hour or 20 times per hour if you're an 8-year-old like I have living at home with me. And 4 times per hour is around your face and mouth and top of your hair. Maybe your hair needs to be readjusted or you're eating or whatever. But this just shows you how many times we touch our face, and there's a surface that probably was touched before we touch our face, because in some cases you cannot not do that. But this is how one way that SARS can be spread, among other viruses. And this isn't the first time this has happened. And if you look at 2002, there was an outbreak of SARS-CoV-1, which was a slightly different coronavirus that happened over in certain areas of Asia and actually made it all the way over to Canada. And this originated from bats in Guangdong province in China and then caused an outbreak in 2003 in humans. And this is kind of the nature of the beast, no pun intended, of where we're headed with this. In 2012, they have this new outbreak called MERS-CoV, which originated from camels to humans, which is a coronavirus that came from what we believe to be originally Saudi Arabia, where the transmission happened, and caused an epidemic in 27 countries and a case fatality rate of about 34%. Way milder than what we're dealing with COVID-19, but the beginning of a story. And then in 2020, SARS-CoV-2 happens, and then now we're looking at this new Delta variant, which is circulating again and causing issues. And I think that what's really terrifying or awakening is that while these have been happening, this certainly won't be probably the last time that this happens in some of our lifetimes. And the question would be, what would be the next one? Because of globalization, because of the way that we're interacting with the environment and population growth and how we're around animals that transmit zoonotic infections, that this is probably going to be another issue for us again. And our response to it would better be pretty good. Hypoxia among patients with SARS is very common and can be silent, and this is something that we learned kind of early on, that many patients present with severe hypoxemia and don't feel bad for a while. And there were patients earlier on in this outbreak that were coming into the emergency rooms because they had a cough and they had no shortness of breath, and their oxygen saturation would be 55%. And we would freak out. And the therapist would come and say, hey, this guy's sats for 55%, and they would put him on oxygen and say, what do we do? And that patient would be on high-flow oxygen before long, and then sometimes on BiPAP. And then there's these two types of COVID-19 pneumonia that have been described based on these differences in lung mechanics that are starting to be recognized. So this COVID-19 pneumonia phenotypes, this type L or type 1 non-ARDS type, tends to have normal to high pulmonary compliance. They have low lung elastance and low lung weight, and they have low lung recruitability mechanically. And compare this to type H or type 2 atypical ARDS, or typical ARDS, and they have reduced pulmonary compliance, high elastance, high lung weight, and high lung recruitability, and they seem to behave very differently from each other, which may be related to how this evolves in that these patients versus these patients may have more direct lung injury, and the other phenotype has more endovascular injury from the blood vessel defects that happen with this infection. You can have overlap between these two, but they're well described and growing in literature. So there's also these effects that happen outside the lung or outside the alveolus that SARS-CoV-2 can do, or COVID-19. It's well described that you have a cytokine storm, and in fact he talked about that a little bit earlier on, that in the latter part of the inflammatory phase of SARS or COVID-19, this cytokine storm happens where these mononuclear leukocytes, which would be polymorphic nuclear cells, monocytes, and several other white blood cells in the immune system, will release these pro-inflammatory proteins that just cause all sorts of damage to tissue. And then there's a well-described COVID-19 related hypercoagulability that has been growing in literature and reported at centers all over the world, where this prothrombotic state happens, where there's a lot of fibrin and fibrinogen and small vessel clotting that has been seen on multiple autopsy studies in patients with COVID that may contribute to mortality and also cause problems with ventilation in the lung by causing small microcapillary clot that prevents oxygenation. So I'm going to tell you a little bit about some humans that I know that have had SARS. And I think one thing that's probably real disheartening and also symbolic of this whole epidemic is that I would bet that if you don't have somebody that's really closely related to you that died from COVID, you know somebody who does. I know many people who died from COVID. I had a family member who had a lot of chronic illness that died from it, and she died in an emergency room in her driveway while her spouse watched them do CPR. This is a person that I know and work with, and let's call her Jennifer because that's not her real name. She's 59 at the time, and she's a Caucasian female. She had hypothyroidism and hyperlipidemia and what would be considered moderate obesity. She developed a cough last July, so a year ago from this July, and fever, and she came to the primary care clinic. She has a primary care doctor at UAB, and she got evaluated. She works in some form or fashion in healthcare. She was diagnosed with COVID-19 by a nasal swab that was available, and she was hypoxic on evaluation, but not looking too bad, and she didn't want to go to the hospital and be admitted, so they gave her oxygen to go home with, and had a plan to have frequent follow-up checks with her. Super compliant patient. She did everything she was supposed to do. And they actually gave her steroids then because this was earlier on, and the guidelines were still evolving and changing, and they were trying to prevent worsening lung injury, and she was hypoxic, so she would still meet criteria for taking steroids at this point. She actually went to the UAB COVID clinic, which was up and running by this point. 3 days later, she gets admitted to the hospital because she's so short of breath that she can't stay home anymore. She fought it off for a while. And she gets transferred to the MICU on a non-rebreather mask the next morning. This is her x-ray the day she came to the emergency room, and it looked pretty bad. She was real anxious and short of breath, but she stayed on a high-flow nasal cannula at 100% and 70 liters flow for 5-6 days at least, and stayed that way the whole time. Couldn't move without desaturating. She couldn't cough without her oxygen level dropping, but she never got intubated. And on day 6 or 7, she just started getting better because time happened and we gave her enough supportive treatment. And then she got substantially better the next week and went home. She did have some chronic issues, but she came back for follow-up, and this is her CT scan in January, so several months later, July to January, in the post-COVID clinic, and it's pretty much almost resolved. She has no oxygen requirement anymore, and she's walking around on room air, and she's working. She does have residual fatigue, but does pretty well. She's back working 100% full-time, made it through. But for 5 to 6 days, she sat right on the cusp of being on a ventilator and was terrified. And this is a very different human story of another person that I know. This guy's Peter. That's not his real name. He's 48, and he's an African-American guy with a history of some obesity. He's overweight and high blood pressure. And he had been actually admitted to the hospital a few years before COVID ever happened because he had some poorly controlled blood pressure and was short of breath, and he had to get some treatment for this. He tested positive for COVID because he just felt bad, and he went through one of the drive-through testing clinics. You get in your car and you drive through a parking deck and they swab you in the nose. And he didn't feel very good, but he was doing okay, and he tested positive. He actually, the day he tested positive, they called to tell him you tested positive, and he was short of breath, and he called EMS to come get him because he couldn't breathe. When they got him, his sats were in the 50s, and he got to the emergency room, and right when he got to the emergency room, he had to be intubated on the spot. He declined pretty rapidly hemodynamically and was on vasopressor support within a few hours, and he was in the MICU later that afternoon. This was his chest x-ray on admission, and this was a CT scan about 4 weeks later, and he stayed in the hospital for a long time. He continued to decline, and he was soon on dialysis and prone ventilated, where they put him face down to help with gas exchange. And he had been given steroids and usual supportive care for COVID-ARDS, and couldn't take remdesivir because his renal function was too bad, but he remained paralyzed and sedated face down on a ventilator for almost 4 weeks, if not more. And after 2 months of being on the ventilator altogether, he finally got extubated. He developed breakdown of the skin of his face because he was face down for so long just to stay alive, but he lived. And after 3 months total of being in the hospital and a whole lot of rehabilitation, he went to a rehab facility. About a day after getting to that rehab facility, he became real somnolent, and he came right back to UAB and had a cardiac arrest, and he died. Both about the same age. Both of them had kind of similar comorbidities, very different outcome, right? And so one of the things that's really interesting about this, or terrifying, or both, is that there's so much we don't know about the disease and why it's so different in different people. And it's really kind of widespread, and it's really taken a lot of us out. So there's some techniques for supporting people with COVID-ARDS we can talk about, and you kind of stratify them in mild to moderate disease or severe disease. This is kind of how we think about this. And when they have mild to moderate disease, you know, they have no oxygen requirement or only mild oxygen requirement. They're alert and not confused. They have no evidence of other new organ dysfunction, so their kidneys are not, you know, misbehaving. And they're able to recuperate rapidly when their oxygen desaturates. So if you're on nasal cannula and you're on a hospital ward and you do become hypoxic briefly, these people tend to have a rapid recovery back up. They'll walk around and try to get up and get out of their room to do, or go to the bathroom in their room, desaturate, recover very quickly. In patients with severe disease, they have moderate to high supplemental oxygen requirements. Confusion or encephalopathy is pretty common. They can have acute kidney injury that wasn't present before from being sick from COVID. They can have a lot of hemodynamic instability, like the guy before. And they can have long periods that need to recover from O2 desaturation. And this is one of the parts where we watch them for a while and wonder, okay, is it time to intubate this patient or not? Because some patients will desaturate and it takes a long time to recover. And we watch them a little bit longer, and then they kind of get to the threshold where it's time to be on ventilation. Mild to moderate disease looks like this. This lady's very happy. She's on nasal cannula oxygen. You can get in the room and talk to her, probably 6 feet apart with a bunch of plastic on. And you can use supplemental oxygen like this or a venti mask and give her standard therapies for COVID-19 like steroids or remdesivir or IV antibody therapy if that's appropriate. And you have to eliminate all aerosolized treatments. And one thing that we started doing early on in this is we got rid of everything that was aerosolized. That means that all the therapists that walked around giving breathing treatments to people in the hospital that have COVID stopped. They never do that. And they switched them to meter dose inhalers. All the patients with COVID-19 have rooms that have negative pressure in the room where they push the machine in to pull all the particles out that you can. When they come to the emergency room earlier on in the days of COVID, they would put scrubbers or, you know, these machines that would ventilate and clean the air into the room as soon as the patient got admitted. And then we wait for them to get better, or after doing all this, or they become this person. They progress. And you know, this severe disease can be treated with titration of devices, including high-flow nasal cannula and now BiPAP, which we're now using, or combinations of these, where some patients will have high-flow nasal cannula and then alternate to BiPAP to give them ventilation, and then go back to high-flow nasal cannula to give them a break from the face mask. Sometimes we use inhaled epoprostenol for supportive oxygenation, although it really kind of just gives them a bridge until they get better. It's not really been shown to change the course of the overall outcome, but it can help. And then recognizing when it's time to proceed to intubation and when it's okay to wait. And this is one of the trickiest parts you could imagine for these patients, because I have seen patients on high-flow oxygen who will desaturate rapidly, and then they will and then they will recover, and then the same person will desaturate, and then it's time for them to be on mechanical ventilation. So this part is a little tricky, and there's some art to this, and some patients will fool you and never be intubated, like the first one, and some people come in really sick. So this is about sort of airway management in patients with hypoxemic respiratory failure. And we, as nurses and doctors and respiratory therapists and other people who work in healthcare together to take care of these patients, had to learn a lot about the disease on the fly as it was evolving. And when this first started happening a year and a half ago plus, there was a lot we didn't know, and we were all afraid. In February and March of 2020, anyone coming to the MICU or to an ICU, at least at UAB, who was requiring 6 liters of oxygen or more, immediately got intubated. Immediately. This was the protocol because we didn't know that you could use high-flow nasal cannula or other modalities. We didn't even know if you could use high-flow nasal cannula safely without aerosolizing virus and infecting people in the room. So we didn't for a while until we saw more information about it coming out of places really like China, which was where it was first emerging, and they have more data about this. We didn't use BiPAP earlier on in this pandemic, and now we do that a lot regularly. And we didn't know how to sedate patients that well. And if you could describe one thing, and ask any of the MICU nurses or a respiratory therapist, what's one of the things that's unique about COVID patients is that when they're on mechanical ventilation, they require incredible amounts of sedation to have adequate lung mechanics and to be comfortable. We have had patients paralyzed and sedated longer than you could ever imagine before COVID happened. And the long periods of sedation after they recover, if they do, affects them cognitively in a lot of ways because of things like cognitive impairment and PTSD related to their journey. And one overall principle from the beginning of this was that managing the safety of the patient was important, but also managing the safety of all the people in the room, taking care of them, was just as important. And we were all afraid of what was going to happen if we went in a room and then got COVID. I never met a respiratory therapist or a nurse at the beginning of this who wasn't afraid. They should have been, and I was. And the incredible amounts of stuff you have to put on to get in the room makes for a really long day. So one principle was function over fashion. If you're going to go to the ball, you got to wear the best dress. And in this case, it's these or more. And when we started rolling out protocols for PPE or protective gear, all of us had to be trained or train each other on how much stuff to put on. And this comes into play not only in going into the room with the patient day to day, which really the nurses and the therapists do that for hours on end, but when we go in and have to intervene as a team collectively to put a patient on a ventilator who has COVID. This plastic, this is kind of the luxury model. We ran out of these a few months into this and started having to wear disposable ones and then cloth ones, and then we ran out of those for a while. And if you could imagine, this is a layer of this, 2 pairs of gloves, N95, a face shield, a hat, and you have to wash it as you go in, and as you take all the layers off, they have to be done in a particular order, and then wash your hands with gloves on to get everything else off. And that was hard to learn, not because any of us are not educatable, but because it's a lot to do it over and over again. And every time you go out of a room with a patient with COVID and come back in, you have to put that whole thing back on. And to get 3 people, which is kind of the minimum you're going to have to put a patient with COVID on a ventilator in a room quickly, all 3 of those people have to have all that on in about 5 minutes, if you're lucky. So there are some substantial differences between the risk of droplets versus aerosols, just in general, but specifically related to this. There's a risk of contracting COVID-19 from infected patients is mostly droplets, as you saw, and that's how it happens in the community. And then fomites, secondly, which is where it drops on the surface and you touch it. But it can be suspended in smaller water particles, and it can, with water vapor in the air, and spread further. So the 6 feet apart goes away when you get smaller stuff. It can stay in the air longer. And so this was encountered during intubations. And there's several procedures that happen during patients with COVID in the hospital that actually are high aerosol generating procedures. Putting them on a mechanical ventilator is one of the highest, and then followed not long after that by putting tracheostomies in them or suctioning them when they're not on a ventilator, which therapists and nurses do all the time if they have to, and other things like mouth care. So these are all potentially dangerous procedures. If you look at this table on the right, you can see these aerosol generating events, and the top one is coughing, which non-intubated people with COVID do a good bit. Patients on high flow nasal cannula that cough could be spreading droplets of COVID way out, further out in the room. Cardiopulmonary resuscitation in a patient that's not intubated that has COVID is a mess. And we put together protocols specifically for that problem, but people who require CPR, you don't have time to get a lot of stuff on. You have to get there fast to do this. And laryngoscopy and some other procedures that go down the airway are all related to this. So there's some solutions to minimize aerosol exposure of virus. When it comes to coughing, we have to wear PPE to the max when we're coming in close contact with these patients. Minimize the interval between. for removal of patient's protective mask and managing tracheal extubation carefully. So, one thing we did in addition to all this was that we got rid of all nebulizer treatments in patients who have COVID until they're convalesced. Positive pressure ventilation with an inadequate seal can also cause problems with this. So we had to come up with a lot of protocols to deal with aerosolization in the hospital. And so one thing that actually increases safety is to limit the number of people in the room. And many of you probably have participated in intubations in patients before COVID happened. And in those days, 18 people would be in the room sometimes. People would walk in and out of the room and bring you stuff that you needed, like medications. But a lot of people would come in and out to help. And in this case, you can see this diagram. There's, at most, this patient, this airway person who's managing it, and these 2-3 other people. And at UAB, it tends to be the operator who's the doctor, the respiratory therapist, and the nurse in the room, and that's it. And there's one nurse who usually sits right here that hands stuff through the door. And in a really well-controlled situation, this works great. And if a patient is about to stop breathing altogether, you might be still putting a plastic on while they're not able to breathe. And we would even not bag mask ventilate patients at the beginning of COVID because we weren't sure if that was going to aerosolize the room. And we do now some. So these are some guidelines from 2020 on COVID-19 airway management from, this is the SAS, the Anesthesia Society, and they want things to be safe during the intubation of a COVID patient, accurate, and swift. And so it needs to be safe for the staff and the patient. It needs to be accurate, avoiding unreliable or unfamiliar techniques, and it needs to be swift and timely without a delay. So if you think the patient needs to probably be intubated soon, or if the therapist says, I think this person needs to be intubated soon, that usually involves a pretty rapid assembly of all the stuff you need to have it right there and then in the room with the minimal amount of people needed in the room and all the medication you're going to need ahead of time. Some things that are also helpful. The most experienced clinician typically does the intubation. So this was not a time for training a lot of rookies in the case of patients who didn't have a lot of time to get things done. Single disposable devices like laryngoscopes that could be used on the patient and then not reused were important, including bronchoscopes that were used. So devices that would go down in the patient's airway were disposable because we didn't know how long COVID would be on them or if cleaning them would be safe. Use of checklists. So there's typically a person outside the room that has a checklist that goes over all the things for the intubation before it happens as fast and effectively as possible. Again, minimizing people in the room, negative pressure in the room at all times. Using simulating devices or simulation to train people prior to them becoming operators so that they're not practicing on patients who have COVID. They're practicing on mannequins and simulated computer programs so that they'll get more experience first that way. And of course, we really switched to almost complete use of video laryngoscopy where the scope has a camera. And one of the reasons why that's important is at the time, in the old days, the old ones, you had to put your face down right in the patient's mouth almost to see. And now you can stand back and see it on a camera screen, which keeps you away from viral particles while you're wearing all the equipment. And then you had to have everything in a bag, the what to bring to work bag. In case any of you are wondering what the most expensive handbag in the world is, it's this. It's made out of crocodile skin and it costs $382,000. I don't know why anyone would need that, but this is a fact. But we started making these airway bags so that when you had to go to emergency codes or events where patients with COVID were going to stop breathing in the hospital before they got to the ICU or in the emergency room, they would have everything in a bag ready that you could possibly theoretically need for 99% of patients with COVID, which would include all of these things. And so what we discovered is that if you have to put a bag in the room and you can't bring all the equipment from outside, is to streamline it and to have it all handy and to have it all ready at one time and to have several of these ready. There were times in 2020 that we ran out of these every day because of how many people with COVID were coming in and getting intubated. And it's better now. we're seeing much less, almost certainly because of vaccination. So, and it's a team effort. So there's not one person that's more important than anybody else who's in that group of people in the room. The patient is important. The operator who has experience is important, meaning the anesthesia physician or the pulmonologist or whoever it is that's operating, putting the tube in, and the respiratory therapist who's helping with all the other aspects of the ventilator as soon as it's in and with the tube, and the nurse who's in there with all the medications and helping with stabilizing the patient. Everybody is important and equally important in that aspect. And we had to learn to do this rapidly. And if you learn nothing else, it's that the reason we had to learn how to do this is to get to places like this where somebody goes home. Because for a long time there weren't many going home. You know, a lot of them were not. And that's it. I made it really kind of short and sweet because I wanted to talk to you guys about that and to show you the world's most expensive purse.